have a lot of fibrosis and lymphedema. But I think it's a stereotactic radiotherapy definitely could be one of the options.
That's right.
I will definitely wouldn't have unless the patient have an MSI and it proved to be MSI high.
Which again we didn't know at the time, of course. But yes, that would be the clinic. Now I'm there waiting for these patients to come back, and there's not much. Some palliative chemotherapy probably will be the next.
Any questions for Kyle? Yes, please.
Because when patients start with PCM, was pharmaceutical 3, is that allowed?
The
PSA was 3. PSA.
Okay.
Performance status was always 0.
Okay. Yeah.
The PSA was 3.
Tarek, any question? Dr. Abdullah? So thank you very much, Kyle, for this interesting case. We have a question.
Thank you for this nice presentation, Dr. Carla. Please, I wanted to ask about the last case. The patient has sciatica, left side sciatica.
A little bit, when he progressed.
Improved on, yes, it infiltrates, the mass infiltrates the sacral roots and also the biform muscle. And I see in the follow-up after treatment, there is improvement or partial improvement of the mass regarding zero infiltration of the nerve roots. Is the sciatica was reversed or disappeared?
I did expect it to be very miserable with that, but he wasn't. He was just told that they had a little bit of sciatica, but not enough to take painkillers. But this is why I started on steroids, and he's now completely asymptomatic, so there are absolutely no symptoms of sciatica. So he has improved, but it wasn't that excruciating pain or symptoms. He was comfortable sitting down, and that's why I took steroids. But amazingly, he never had
Thank you.
And now with my dear colleague, Professor Muhammad Abdullah, Professor and Head of Oncology Center, and he will talk about the hormone sensitive and castrate resistant. More for patients with hormone sensitive disease, we have more 3 subdivisions. Those with oligo versus low and high hormone of the disease. For patients with metastatic castrate resistant, we have those identified with germline and acquired somatic mutations, as well for the hormones indifferent disease. And we have therapies dedicated now for any of them. Across the spectrum, we do expect that the survival is going to be more and more compromised, while the disease burden and mortality will be accentuated. And now we are living in the era of treatment intensification, but when we go for the real world practice, and this slide is quoted from the presidential session in the ASCO 2023, that not all patients are receiving up to standard treatment. Still, patients are receiving under treatment. In Europe, about 30% of patients are just receiving the doublets and triplets, while in the US, maybe because of the health system there, up to 50% are going to receive up to standard treatment. So the question is, why we have compromised outcome in spite of the castration, whether medical or surgical? The answer is coming from the control arm of the stability trial. The ADT alone will offer median failure-free survival of 11 months and median overall survival of around 42 months. So ADT alone is not always appropriate, and intensification might be required, particularly as data coming from such a trial, those with bone and soft tissue, metastasis, lesion score 8 or more,
performance is somewhat compromised, and for age younger than 60, and step forward for more refining the approach. The patients with high volume metastatic disease would have the worst survival as opposed to those with metachronous metastasis after diagnosis and with low volume. Step 4, we identified the real role of docetaxel in the management of the platform, that it is only of value for those with synchronous presentation, high or bulky volume of disease. To move ahead, to go for doublet or triplet, definitely triplet is associated with survival benefit. But when we look to the doublet trials and plans, we have data from the Charité for the docetaxel, Latitude for abiraterone, Titan for ABA, and Arches for enzalutamide. Patients incorporated in such trials, in these trials were heterogeneous. They were not only one disease entity. We have some with high volume, some with low volume, and regarding the onset of presentation. For Charité trial, again, the positivity just for the high volume of disease, while for the hormonal agents, the Latitude, Titan, and Arches, they were positive for all. The survival improvement was completely except for the Latitude. It was more pronounced for patients with high volume disease. Patients included in the Latitude, 100% of them were considered of the highest because they have high volume presentation, while we have variable for other hormonal trials. The quality of life was okay and maintained for the hormonal manipulation, while not for docetaxel, but after 12 months from enrollment into the trial, it was the same. So we have many options, many doublets for patients with metastatic hormone sensitive prostate cancer. What about the triplet? We have data coming from the RSS and the PEACE-1 trial, and certain group of patients treated in the ENZAMED trial received the enzalutamide ADT plus docetaxel, and the survival benefit was maintained across the 3 trials within the same range, 70 something for the hazard ratio, and it was positive for both high and low volume in the RSS, while for high volume only in the PEACE-1 trial. And it could be the approach for how to choose between doublets and the triplets. That metastatic hormone sensitive prostate cancer, you have to start with the ADT, and then you have to stop and ask a question: is docetaxel is preferred? And we have specific definition or criteria for selection. It should be high volume, synchronous presentation, low PSA production, because those patients usually have dedifferentiated histopathology where the hormonal control would be less than those with high PSA. Patients should be highly fit, and we should be enthusiastic to receive the more intensified treatment or to achieve the best survival. If the answer is no, you can go for doublet and no harm. If yes, triplet is still there, and upon controlling the disease, we can go for locoregional radiation for certain subsets of patients. What about the network meta-analysis? We will tell because we don't have much data head-to-head. When we compare the triplet versus the docetaxel doublet, they are nearly the same results, but it's preferred for the low volume as compared to the triplet and for those with metachronous presentation. When we compare the triplet versus the ADT doublet, definitely there is much less difference in the outcome regarding the overall survival, and the AB doublet or the androgen receptor signaling inhibitors versus docetaxel doublets, the hormonal manipulation arm is usually predominating. For patients with visceral metastasis evaluated in all trials, the Latitude trial was for abiraterone was the first to show improvement over the other trials, and the same data was obtained
from other meta-analyses published in the Journal of Urology, both in year 2023 and 2024. Then to go for a deeper dive for the apalutamide, which is a key player for the management of metastatic hormone-sensitive prostate cancer. And on long-term follow-up, the survival benefit was maintained for nearly for all subgroups of patients, whether we are considering high versus low volume, those with visceral or without visceral metastasis. And in indirect comparison with enzalutamide, apalutamide has a consistent and maintained improvement of the PSA control as compared to enzalutamide, although this is indirect comparison. For high and low volume, if we want to have in order to arrange what we have from the secondary hormonal agents, we can notice that for those with high volume, abiraterone comes on top, followed shortly by apalutamide, docetaxel, then enzalutamide. While for the low volume disease, enzalutamide comes on top, but still we have aba, but not docetaxel. When we choose the treatment, the orientation, and to know what about the expected adverse events encountered with the such agents, it's very crucial. And every one of them had its own peculiar adverse events. They might be shared, but we have something like the CNS complications or the seizures, although it's a little bit low, but it's reported for the enzalutamide and expected to be for ABA, although not reported by FOC for the apalutamide and the others. This slide was quoted from a presentation of my friend, Professor Ahmed, a couple of weeks ago. That it is not only the PSA to be monitored, but we have to monitor for a lot of things. We have to monitor for the level of testosterone to be sure that the patient is staying gastric, as well for the all vital functions in the body. Now coming to the conclusion that your choice should be based on phase 3 trials data, and it's coming for all. I'm sorry for bio because I are not now yet. It's not included in this table because still the data for the overall survival, it's premature. We cannot tell so. The ones they say. Number 2, to have extended published data. For all, it's there. Overall survival was achieved as well for the progression-free survival. For high volume, data were much more enthusiastic for apalutamide and abiraterone acetate, followed by the enza, while for low volume, data were supposed to recommend more enza, although it is there for high and low volume. For the visceral metastasis, still you have apalutamide comes on top. For patients with myocardial disease, enza is preferred. ABA can be used if your patient is well controlled. For uncontrolled hypertension or uncontrolled any other systemic disease, you cannot go for any of them. For history of convulsions, we would exclude enza, although ABA is not reported, but being a cousin of enza in the molecular structure, we can use the abiraterone instead for patients with skin disease, and as apalutamide is associated with a higher significant proportion of patients with skin rash, you can exclude, while for liver, thyroid dysfunction and hypokalemia, although not recognized in our real-world practice, you have to avoid the use of apalutamide. Thank you very much. I have changed the photo at the end of the last slide, because we are with Dr. Samir. So, thank you very much.
Thank you, Mr. for the presentation and for this nice picture you in the session. The floor for any discussion or questions. Do you have any question for the? Do you have any question?
شكرا، كل سنه وانتم طيبين.
The next talk, Professor Dr. Salam Eid, talk about optimizing the treatment intensification with Nopica in MHSPC medicine.
Thank you, Mr. Chairman. I'd like to thank Professor Sanish for the kind invitation. I'd like to thank Fire for giving me the opportunity to share with you the session of GU and the presence of Professor Muhammad, Ahmed, Hisham, and the others. So today I'll talk about the intensification of treatment in metastatic hormone-sensitive prostate cancer. Here are my disclosures, and as you see through the last few years, the management of metastatic hormone-sensitive prostate cancer is really evolving, and the current standard of care, not ADT alone, but ADT plus systemic therapy, either docetaxel, which was before, or androgen receptor signaling inhibitors. It started first by ADT. We achieved up to 3-year overall survival, but when we added docetaxel, it increased up to 4 years. When they added abiraterone to the ADT, it more increased. So these are the examples how the intensification of treatment from ADT to doublet treatment by adding something here, the adding chemotherapy in the shorter trial, as Muhammad said, improvement compared to ADT, while the Titan, there is improvement for abiraterone acetate compared to ADT alone, the ARCHES trial, and later on the Titan trial by apalutamide. As you see, there is consistent benefit through the whole group, so ADT alone is not enough, and we have to add something, so consistent benefit as you see. Again, this is the achievement with chemotherapy. This is ADT alone, and if you add chemotherapy to ADT, this is the achievement, but still good percentage of patients who will need more treatment who are this group. The same as well for patients who receive ADT plus novel hormonal agent is still unmet need for this group of patients who receive doublet treatment, and we need to improve and we need to focus on this group of patients. So we started in the era before by ADT, then this is the evolving, then adding docetaxel again, or adding novel anti-hormonal agents. How can we improve? Can we combine both to ADT? I mean ADT plus docetaxel plus new novel hormonal agents. I mean triplet versus doublet, just to improve this unmet need for such a group of patients who still died from the disease, or at least for the patient who will rapidly go for the castrate-resistant phase. So ADT is not enough. Yes, the standard, at least ADT plus something doublet, but the question is, should we consider the triplet? The problem with the triplet mainly, is it effective like doublet? Is there any superiority for triplet versus doublet? What about adding triplet versus triplet? There is some sort of toxicity you have to consider, especially we are talking about older age in such a group of patients with a lot of comorbidities, a lot of medications. And based on a lot of medication for such a group, drug interaction will play another role. So we have to tackle certain points: superiority, toxicity, and little bit drug interaction. Let's start by efficacy and the study design. I know Dr. Muhammad talked about the enzyme, but it's still subgroup of patients who receive triplets, so we will not take it as an example. But the first example is PIS1. PIS1 is a complicated trial, but we have simply to say that is standard of care, which is changing from ADT to ADT plus docetaxel. So we will consider the standard of care is ADT plus docetaxel versus ADT plus docetaxel plus abiraterone acetate. This is simply the design. So as you see, the trial included all patient de novo. 100% of the patients are de novo metastatic. So they are high risk by the definition of de novo versus metastasis. And as you see, there is 2/3 of the patient will present with high burden disease, high volume disease. So de novo, and 2/3 of the patient high volume disease. So we are talking about relatively high risk patients. So here doublet versus triplet, as you see. In the radiographic progression-free survival, yes, triplet is significantly better than doublet, either the patient high volume or low volume. But once it comes to the overall survival, the benefit may be limited to high volume disease. So patient with low volume disease at least now the data not mature enough to inform us that there is overall survival benefit for patients with low risk group, maybe by further analysis or prolonged follow-up for those groups. Maybe we have some benefit regarding the low volume patient, but at least now the benefit limited only for high volume patients, not for low volume patients. So the achievement now is when we add triplet, we can increase from 50 months overall survival to 60 something months. So we have achievement, especially for patients with high volume disease. What about darolutamide? We know that we have apalutamide and enzalutamide, and darolutamide, they are similarly, as we see in non-metastatic castrate-resistant prostate cancer, they give similar efficacy, but maybe darolutamide, it is potent like others, but structurally different because it's have some low blood-brain barrier penetrations, and so it may be reflected on the tolerability of the drug. This is from the theoretical point of view. How can we look for this in the clinical trial? So from the early and preclinical trial, there is, compared to enza and apalutamide, the darolutamide showed did not affect the serum level of docetaxel when they are combined together. But when we combine apalutamide with darolutamide, they will decrease the exposure of taxanes to the blood. So this is the rationale, because there is no interaction or no drug-drug interaction between this. This leads to safely combine docetaxel with apalutamide combined to ADT, and this is the rationale for the RSS trial. RSS trial for patients with metastatic castrate-sensitive prostate cancer, randomized patient to the standard of care at the time, docetaxel plus ADT, compared docetaxel plus ADT plus darolutamide. So triplet versus doublet. The primary endpoint was overall survival. And secondary endpoint, time to castrate-resistant, time to pain progression, and the others. Here are the patient characteristics. As you see, 85% of the patients are de novo metastasis. So compared to two-thirds of the BIS1, as you see, and as you see in this trial, 77% of the patient high volume and 70% of the patient high risk. So again, similar to the BIS1, still we are dealing for the triplet versus doublet to a patient with high risk disease, de novo metastatic. What about the results? As you see, the trial met its primary endpoint regarding significant improvement in the overall survival for triplet compared to the doublet, with 32% reduction in the risk of death in favor of darolutamide compared to placebo when they added to ADT plus docetaxel. And again, for the secondary endpoint, the same effect, as you see, nice separation of the curve, especially to the progression to castrate-resistant phase, and we know this is the lethal phase of the disease. Pain progression relative endpoint, but the main one we are focusing on the time to castrate-resistant prostate cancer. I mean, how to delay the patient to be kept enough in the sensitive phase and not grow for the resistant phase. And as you see, nice separation in favor of the darolutamide. And for this subgroup analysis for overall survival, all consistent in favor of darolutamide, irrespective to the disease volume or the presentation. Either the patient presented with de novo metastasis or the 15% of patients who already have developed metastasis after localized, I mean metacolous metastasis. Again, for the high volume, as you see in the BIS1, there is nice separation regarding the radiographic progression-free survival or overall survival. As you see, more than 30% improvement in the overall survival for the high volume, expected, yes, in the high volume. The high risk as well, according to whatever the definition you need, either volume or risk. What about low risk, which is, as mentioned before, it is not significant in the BIS1. There is inherent overall survival, 38% reduction in risk of death in favor of triplet versus doublet, which is a new one, making it one of the standard of care here. De novo versus recurrent, the same benefit as you see in the overall survival. So whatever you give your patients, either de novo, I know it is high risk and aggressive disease, but still the benefit for triplet is still maintained again for patients with about 40% reduction in death for patients with recurrent metastasis. So this is the end result, but we have to look for the subgroup analysis. I mean, BSA kinetics. We learned from the Titan trial that we will go to undetectable level of BSA during the treatment, especially at the 3, 4, or any time, we'll have improved survival. So what about the BSA kinetics for the triplet here? As you see, whatever after 24 months, 36 months, or 52 months, or at any time, as you see, there is higher percentage of the patient who will achieve undetectable BSA levels. So maybe 90% reduction or less than 0.0 nanogram per deciliter. So, and this, as you see, it is beneficial, yes, as you see here, it will be reflected on the overall survival. So patients who have achieved undetectable level would be reflected on superior overall survival compared to patients who will not achieve this still detectable level of BSA. Again, in the subgroup analysis, may be limited for high-risk patients or high-volume patients, but here, still consistent, still the benefit, either the patient high volume or low volume. So even the patient in the low volume, and you know, it's not, sometimes we will not give the triplet. I have achieved detectable level of BSA will be reflected on the overall survival. Again, as you see on the curve, either the high volume or the low volume, undetectable level of BSA will be reflected on the overall survival. So it may be a good predictor to assess the benefit and for predictor for the survival of the patients. This is what in the trial, but in the real world, as you see in the ARA trial, which is retrospective study for patients receiving triplet, here they are in this retrospective and real world trial, they try to assess because we have two standard, the BIS1 by ABI or the apalutamide in the Harrison trial. As you see, they assess 4 points. First, the BSA response, time to have discontinuation, the percentage of patients who discontinue the treatment, or progression to castrate resistant, and overall survival. As you see here, the BSA response, either undetectable level more in the RSS rather than in the BIS1. Yes, there is good percentage of patients with BIS1 still we have in the triplet, but more in the RSS trial. Again, progression to metastatic castrate resistant and time to treatment discontinuation was in favor of darolutamide rather than in ABI. The overall survival, as you see that the parameter down is in favor of the RSS rather than the BIS1. So consistent results regarding the benefit. This is in the real world, but we have to remember that this is retrospective and real world data. We have to be cautious regarding the interpretation of this data, but still give us some data how to deal with this. So again, we have 3 examples of triplet. What about the efficacy? We have to conclude about the efficacy in the NZMET. As you see, no suggested benefit. In the BIS1, yes, there is improvement in the overall survival in favor of triplet, but mainly for patients with high volume, the data consistent. But in the RSS, the more separation of the curve in favor of the RSS. As you see here, and was reflected here on the hazard ratio, as you see, 0.9 in the NZMET, 0.75 in the BIS1, or 0.68 in the RSS trial. This is regarding the efficacy. What about toxicity? Yes, it is better to go for triplet, but we are dealing with older patients with a lot of comorbidities. And what about also with drug interaction? Here is the adverse event reported in the RSS trial. As you see, strange enough that you can see that the rate of adverse events are similar between doublet and triplet. Again, the serious adverse event relatively similar and lead to discontinuation of the treatment in only 13% for the triplet compared to 10% in the doublet. So minor difference in the rate of discontinuation. The duration of treatment for the triplet doubled from 1.5 years for the doublet to about more than 3 years in the triplet. So I think it is more tolerable and more effective, so the patient continue the treatment double the time of the doublet treatment. And as you see, again, for another view for the adverse event, as you see the green and the blue one, as you see, they are similar adverse event between the triplet and doublet, so no concern about the adverse event for this drug. And they noticed that the most of the adverse events are noticed during the time for during the time of the chemotherapy, but later on they decrease sequentially. They decrease by the time, and even at the time of chemotherapy, there is no big difference between the triplet and doublet regarding the incidence of adverse events. So we have to consider it and put this into consideration. One of the important points regarding the androgen receptor inhibitors is some CNS manifestation due to CSF penetration, but here, as you see, the incidence and ratio of the drug from brain to the blood is so lower in favor of the darolutamide, 8% compared to the ABA and the enzalutamide. So one of the benefits regarding these agents, and as you see, there is the regional cerebral blood flow are higher in the darolutamide, are not affected like in the enza. So this is one of the points in favor of the darolutamide, and this was reflected on the CNS symptom of the disease, mainly the fatigue, as you see through the trials of using darolutamide, either the Aramis, Arano, and the Aracins. As you see, the incidence of fatigue, which is one of the side effects of androgen receptor inhibitor, are similar between darolutamide and placebos. They did not increase the incidence of fatigue for such patients. One other point which is really important as they compare the drug-drug interaction, because we are dealing with older patients with a lot of comorbidities, a lot of treatment, it was in favor of darolutamide, the least one to have drug-drug interaction compared to the other drugs and again with chemotherapy. This lead to, as you see, the incidence of the median number of patients who completed chemotherapy for the triplet, the same as well like those triplet or doublet. So did not affect the number of cycle or exposure of docetaxel treatment. Again, because of this tolerability, as you see the incidence of the discontinuation of the treatment, as you see in the trial using the darolutamide, they are similar, no higher incidence of discontinuation versus placebo. But when you compare it with other agents as reported in clinical trials, this is not head-to-head trial, but the incidence of treatment discontinuation was lower in favor of darolutamide compared to ABA or enza. And again, the same concept as well, whatever the cause of discontinuation, this is for a retrospective real-world study also showed this. This was in the clinical trial, but this is in the retrospective data and real-world. The incidence in favor of darolutamide, lower rate of discontinuation, this is either because of the adverse event or the efficacy or other factors. Again, another important point, because most of the patients with prostate cancer are already patient older. So how can we deal with patients more than 75%? Because can we go for triplet? This is a subgroup analysis for 20% of patients over than 75% represented in the Aracins trial. As you see, they compared the survival between those patients and those patients younger than 75% who received triplet versus doublet. As you see, similar overall survival benefit, either the patient younger or older. This is my explanation, may be due to the good tolerance of the treatment rather than it is effective, yes, but the tolerance may be lead to those patients can have this outcome and continue treatment. The same as well, not only overall survival, but time to castrate resistance and time to initiation for subsequent treatment. There is marginal improvement, marginal increase in the adverse event, but this is mainly because the expected toxicity in such a group of patients, and it was also reflected in the placebo group like the treated group. So the increase here not related to the drug, but mainly related to the age itself. And the median duration of treatment, they still consistent with the treatment, continue the treatment, similar to patients younger than 75%. This, I know that is not meta-analysis direction, but it's network meta-analysis. Try to assess triplet versus doublet. Yes, for triplet versus doublet, it's superior, especially in patients with high volume, high risk disease, and also we can include patients with low risk disease, darolutamide and abiraterone acetate, but more in favor of darolutamide. Again, from the low volume and high volume, they are consistent both, but maybe some superiority for the Arasens versus the BIS1. So my final take-home message regarding the treatment of metastatic castrate-sensitive prostate cancer, as Dr. Muhammad said, yes, treatment daily is really evolving. ADT alone is no more the standard of care and not enough. Maybe in certain situations and very selected people. Doublet treatment by adding chemotherapy or ABI, ENZA, ABA, I'm still insisting by putting chemotherapy till now, to ADT significantly improve overall survival by 4 and now 5 trials, but still some patients still have poor outcome and need more intensification. One of those groups is de novo metastasis, I mean synchronous metastasis compared to metachronous, have poor outcome compared to metachronous. High volume also versus low volume has inferior outcome. So maybe intensification of treatment for such a group of patients may be, triplet may be beneficial than doublet. So ABI, when added to docetaxel and ADT, I mean triplet versus doublet, in the BIS1 significantly improve survival, but the data are limited to high volume and high risk disease. Darolutamide, again in the same design, added to docetaxel and ADT, showed significant improvement in overall survival. The combination is uniquely improved the outcome without any added adverse event or just mild difference in adverse event. This is mainly related to the non-favorable safety profile of the darolutamide and the relatively lower incidence of drug-drug interaction. The outcome is maintained, even the patient younger or older than 75%. It was also reflected on the patient PSA response, which later on reflected on the overall survival, even the patient with high or low volume. The good tolerability led to lower rate of discontinuation and prolonged exposure to treatment. So after the era of doublet therapy, escalation using triplet therapy is very attractive, especially in de novo metastasis, I mean synchronous, high-risk patients, but adverse events, patient profile, efficacy should be taken into consideration. Thank you very much.
Thank you very much, Professor Seven, for this elegant presentation. Actually, I have two questions. The first question is, I didn't see in the presentation of Dr. Muhammad Abdullah or in your presentation the subsequent treatment of patient failed on the triplet therapy, because this is a very big issue. I bring ADT, I bring hormone androgen receptor pathway inhibitors and chemotherapy. What about? I know that we have a subsequent treatment, but we didn't see in any of the trial these subsequent treatments. Why?
There's reports regarding this, I didn't put in my slides, but they tried from either if you use ABI to go for androgen receptor inhibitors, I mean ABA, ENZA, or whatever, and they may go for others like cabazitaxel. Unfortunately, they have the same magnitude of benefit, no superiority for any agents. But as you know, Dr. Ahmad, now we are going through the area of precision medicine. So I think if you started with triplet, you have to go for something like BRCA or something like this, or go for cabazitaxel.
I agree. You should have an HRR mutation,
Yes.
and also you have the mutation now.
Yes.
But I didn't say in the trial actually. The second question is, do
But
you
it was there. It was there, but no difference.
Uh-huh.
Whatever they get their capacity, like Lucy, they reach out with Lucy again, and they are the same.
Okay. So, do you change your mind after the Aranot trial if there is an improvement in overall survival? And I do believe that it will have an overall survival benefit. So, do you change your mind to go for the tablet or the treatment to start?
I will always go for triplet for the two subgroup patients, the high volume, high risk, and the low risk. But Arasens mainly the tolerance already. I used the BIS1 in about 3 patients, and they are tolerated, but more tolerance, especially in older age with the Arasens.
So you will make the triplet and
Yes.
not the tablet.
Yes, especially for
the
such
high
patient.
volume,
De novo.
de novo,
Yes.
visceral disease.
Yes.
Okay.
Dr. Salim, if this benefit is sustained with neuroendocrine also approved?
No. Neuroendocrine differentiation is an
Outside the
evolving field.
treatment.
Yes, and we have to change treatment for chemotherapy and we expect a poor outcome for these patients.
By this, we go to our end of this session, and the floor is open for the next session. Thank you for